to enlighten you about lid trauma management. So my overview of the lecture is on a few components of the lid laceration, which lid trauma, which includes lid laceration and then lid burns and other factors that can confuse in the trauma management. So it is a lid laceration, you can see, and when you have a lid laceration, see to extent, and you should know what you should look for. And then some burn patients with final scarring, and starting with general outline for lid repair principles. First, you need to assess and do the initial management, then do the lid laceration repair and check whether there is a canalicular laceration and that needs repair as well. Then post-op care and to know the complications, detect them and manage them. So basically, you have to do the assessment and initial management, whether it's lid or canalicular, then post-op care and look for complications like infection, lid malposition and other considerations. So assessment and initial management. So you see a patient like this coming into the trauma unit, and there are many things that go through your mind. Always ABC, airway, breathing and circulation. You have to make sure the patient is alive before going into the eye. So initial evaluation is very important. You have to take a thorough history. That includes the mechanism of injury, the velocity, whether the accident involved, whether there were mortalities. So that gives an indication as to the mechanisms or the dynamics of the trauma. Then detailed examination has to be done to evaluate the extent of the injuries, and also check for the associated injuries. There might be globe rupture, the eye might be damaged, there might be orbital fractures, and there might be other associated facial trauma. Then the lacrimal system, especially the lacrimal drainage system, because it is one of the most important functional component of the eye. So assess it thoroughly. So you have to see the beginning, that is the punctum, and then from punctum goes towards the nasal side, and the tears are drained into the nose. And the canalicular system's integrity should be checked. Especially when there are injuries near the medial canthus, you should always suspect a canalicular damage. So basically, going back to the same thing, mechanism of injury, what is the type of impact, the force, and with that, whether there are globe ruptures, orbital fractures or associated injuries. So to determine what has happened, you have to take a good history. Examination can be major injuries, which is life-threatening and needs complicated surgery, minor injuries, and the extent of the injury. So inadequate assessment of facial and eye injuries might lead to serious complications, which could have been prevented. So you need to know about a little bit of lid anatomy. So basically, if you take the lid, you can divide it into two layers, anterior lamella and the posterior lamella. So anterior lamella is the skin and the orbicularis muscle, and the posterior lamella. The posterior part includes the meibomian gland housing tarsal plate and the conjunctiva. So ideally each layer has to be repaired separately to restore the proper function both anatomically and physiologically. So if you don't have a proper position, then the lid might not look in its normal curvature, and there might be ectropion, that is lid can turn out or lid can turn in, which gives to loss of lid integrity. And the other area, especially in the upper lid, if you see a damage, always don't forget there might be a levator damage. So levator is the muscle which elevates the eye, like which keeps the eye open. So when you see a lid laceration with fat prolapse, always be conscious that there might be a levator injury as well. So other problem area is the lateral canthal tendon damage. So you might be having a trauma around the lateral part of the eye, the lateral angle, and you might have it's an acute angle. It might be a little rounded. So it's not difficult to repair, but once you repair, you can have a correction like this. And medial canthal damage, lateral canthal damage, if the tarsal plate is damaged, you need to attach it to the periorbital rim using absorbable or non-absorbable sutures. Medial canthal damage is a little more tricky area because you have this lacrimal drainage system, and it's little difficult to repair. So sometimes bilateral, sometimes with trauma they can arrive. So when the punctum is not in place, then the functionality is also you are having trouble, and the corneal exposure might be present as well. So there are many ways to correct the repair. So ideally you have to, it's not very easy to catch the medial canthal tendon at its medial end and attach to the bone underneath, because you need to attach it deeper. So best way is, like, technically you might have to do another separate incision and go there, and then first attach the medial end of the tarsal plate and come through the defect that you have created, and then go and insert the sutures. And like the previous case, you might have to do a screw and tighten it to the screw, or sometimes you have to do a transnasal wiring when both sides are affected. So canalicular damage. So as I mentioned earlier, the sputum goes through the canalicula, goes to the tear drainage system. So if there is a damage, you should make sure it's repaired. Other concern is a tissue loss. So if there's a small tissue loss in an old patient, the tissues are stretchable, so you can make a proper repair. But if it's a large tissue loss, you might need additional support by mobilizing the surrounding tissue or putting grafts. So a few salient points, like you can repair in these techniques. And here, to prevent doppia, you have to have a slanted incision. And few other, in a lower lid defect, you can make it suture it perpendicular to the margin, but upper lid, if you can have something like parallel to the margin. And other trick is, if there's a defect, make the defect lateral. So it's easy to correct the lateral deformity. So mobilize the skin over here and suture it, and then laterally it's okay. It's functionally, the functional components are mainly in the medial side. And reconstruct the anterior lamella, that's the the anterior two layers and posterior two layers separately, not at a single go. And one lamina at least should have a blood supply. Then the other thing is levator identification and suturing, and if you can do the levator surgery at the same time, it's all, if you are competent, then it's all right to go ahead. Otherwise, just note down for future reference for the ophthalmologist or oculoplast surgeon to manage, and to manage the canthal injuries, medial and lateral. So these are the ways that you can approximate laterally out. And the surgical approach. So what do you do? Generally skin, you can use a non-absorbable 6-knot or 7-knot prolene or nylon, because the bicryls, they tend to give scars, and eyes are not the ideal place to get scars. If there's a significant skin loss, you can have a graft. For the muscle, you can use bicryl 6O absorbable. Tarsus, you can have few interrupted sutures after correcting the lid margin. Then conjunctiva, usually it heals on its own, but you can use a 8-knot bicryl. And the most important thing is the positioning of the eyelid, and make sure that it's slightly everted initially to prevent deformities, and it should be in a single line after it's healed. So canalicular laceration, you have to know a little bit of anatomy. So you have the upper punctum, lower punctum. It goes, so this is the outer side, this is the nasal side. So it goes slightly vertically and then goes horizontally, and most of the time becomes a common canaliculi, and then enters the lacrimal sac. So it has a body, fundus, and then it goes through the bone and enters into the lateral wall of the nose. So that's how, with the blink, the tears are produced more or less on the lacrimal gland, the main lacrimal gland and accessory. Then when you blink, it moves from lateral to medial, and with the blinking, the tears drain down. So it's a production and drainage as well. So if you have a blocked drainage, then you might have tearing of epiphora. So anywhere along this path, if there's a trauma and the scarring, then you would have tearing as a result. So evaluation, so you have to ideally have a microscope or a surgical loop or magnified beam to evaluate. And the repair techniques, I won't go into detail because it's a delicate structure. You have to repair it. So ideally, initially, if you can, repair within the first 3 days. But up to 1 week, if you put stents, then the results are very good. So post-op care, you need to put some antibiotics. Especially prophylactic antibiotics can be given to prevent infection, especially if you suspect contamination or if the repair is delayed. Then ointments you can apply for lubrication purposes, because the moist wounds promote well and to prevent dryness. And you need to have follow-up visits planned to monitor for infection, wound adhesions, it's not so uncommon, and to see the complications such as entropion and ectropion. And complications management. So if there's infection, then you have to think of systemic or local antibiotics when the signs of infection appear. And if there's tear duct obstruction, then they might need further surgery like dactylocystine rhinostomy in the future. And if there's lid malposition, you have to detect it and you might have to intervene in the future. So considerations: timing of the repair. So ideally early, within 24 hours, but you might need further time for complex reconstruction. And make sure you address the other facial fractures as well with the OMF and the facial surgeons. And there might be ENT involvement for nasal injuries. And always it's the face you have to think of functional as well as cosmetic outcomes. So you are aiming to preserve vision, tear drainage, as well as to have better cosmetic outcome with proper eyelid positioning as well as minimal scarring. So in summary about lid laceration repair, managing canalicular and lid laceration needs careful evaluation of the injury, then proper surgical technique and attention to both functional as well as cosmetic outcomes. So for that you need to have a solid understanding of the anatomy and repair principles and timely interventions to prevent the complications. So you can have all these theories in your mind, but then what you will be facing is something like this. So all these theories might go out of the window, but you have to be very practical, try to adhere. So this is a trauma which has, so see how they have managed. Most of the principles have been addressed. So the verticals like suturing, lower lid, upper lid, this is, you can say, according to injury they have managed well. And in the brow you have to have suture to a position. Make sure you suture here and here. So when you have a straight brow, then go suturing from that. So like the lid laceration as well, you need the margin you have to prepare first, then you have these edges, and then you fill up with the other sutures. And from here, if there's not much of functional effects, then you have to manage the scars later. So something from this to this is possible with minimal complications. Then I will move on to other important topic. It's a lid burn, how to manage. So lid burn, so it can be due to thermal injury, chemical, electrical, as well as sometimes radiation injury. So thermal injury, how is it? The heat causes is like with generally the flames as well as hot water, hot liquids, cold. So generally speaking, any chemical injury to the eye, you have these protective mechanisms. So first thing is you put your arms to protect your face, and then there are other eye protective mechanisms as well. You have the blink reflex, you have the Bell's phenomenon, where the eye spontaneously eyeball rolls up to protect, and then with those generally the lid is protected. So how does the heat transfer? You have conduction, convection and radiation. So all you have to remember, even though just you think you go out from the source of the heat, but still this heat and convection can damage, bring out damage. And how does the burns do the damage? So it's about intensity into time of exposure and the skin thickness. So the lid has very minimal amount of thickness because you have the very little subcutaneous fat, so it's very thin. So it's more it can damage. Deep burns are not so uncommon. So intensity, like if you have 44 Celsius degree burn, Like ours of 44 degrees won't cause any harm. But 60 degrees Celsius for 1 second will give you a partial thickness burn. 70 degree for 1 second will give you a full thickness burn. So there are this tissue model called Jackson's burn model. So you have circles. So you have in the middle you have the necrotic coagulation of coagulation, all dead tissue. Surrounding them it's a dying tissue, but treated carefully they might recover or they might turn into this necrotic tissue. And zone of hyperemia is the normal tissue with dilated blood vessels supplying the blood to the healing process. So these circles are dynamic, if there is no infection, blood supply is good, no nutrition is good, then these shrink and these are dynamic, so they don't stay stagnant. And if there is infection, so this might spread to the other way. And you have to know a little bit of burn depth, first degree, second degree, third degree, and sometimes you call it a fourth degree. So first degree affects the epidermis, red burn because the nerve endings are affected. It's painful, and these might take 2 weeks to heal. Generally they heal without scarring. So second degree, it's more painful because epidermis is also involved, and you can have blisters as well. So third degree, like you have this eschar formation, and it definitely it heals by scarring and starts healing from the peripheries. So fourth degree you also call it when you have associated bone and other tissue injuries as well. So first degree burn, blisters, painful. Second degree, this is not eye but still just to go through. And third degree, on sometimes fourth degree, it needs complex intervention from multidisciplinary teams. So ultimately scarring and loss of vision. So immediately what you do? So first thing you need to do is to remove the source of the burn. So and then cool the burn. So wash it with running water, like 15 to 20 minutes, but not ice. And do the assessment. So evaluate the extent of the burn, whether it's first, second, or third degree burn. Then check for any associated eye injuries and vision damages, which are luckily very, very rare due to the protective mechanisms. Then in an event of a blast, consider there might be some foreign bodies. Do a CT or chest X-ray just to make sure you are patient wise and medical legally you are safe, and make the ICU patients have greater risk. And especially not only ICU patients, children, patients with physical disabilities and psychological difficulties have much higher risk. Ideally, assess early before the edema sets in. So initially at the time of burn, sometimes you can have a proper understanding. So what you really need for the examination, ideally portable slit lamp and a speculum for both adults and children. Fluorescein strips to detect corneal epithelial defects and corneal damage. Good illumination, always very important. So like proper torch or light in a very illuminated setup is direct ophthalmoscope is useful, because that's something we use to check for fundus, but it has a magnification view, and then it has some light source, and sometimes you might have a peek into the eye to make sure eye is all right. Toner pen is something that you can use to check the eye pressure. If there, it's very useful, and always take a photograph to because later on with your workload, and you might forget what has happened with the patient. So what does lash loss indicate? So it indicates there is a deep burn So lash loss in lid malignancies is not a good sign, So like that, this also indicates deep burn. And also the margin is not intact, and you have meibomian gland deficiency. So when you have the inner layer which there is the opening of the meibomian gland. So generally it is damaged. So that means they might have long-term dry eye problems, because meibomian glands are the one which is giving the outermost lipid layer in the tear film. So what does chemosis or the swelling in the conjunctiva means? So this might be due to fluid resuscitation. People with burns, they give fluids very fast. So these fluids are moved from the intravascular to extravascular component. So this is another place that you can have chemosis. And there might be conjunctival thermal injury, there might be exposure, and you might be having some other high intraocular pressure due to high venous pressure due to cerebral injuries as well. So corneal rare thankfully when they have poor Bell's phenomenon. Bell's phenomenon is the eye rolling up as a protective, and then the eyes are not closing properly. It's lag ophthalmos, they are at higher risk. Sedated patients are another set of people that they are more vulnerable. So other thing to remember, these can occur later, not at the initial injury itself. So this can even occur without any significant burn, swelling, but still the cornea can be, and especially after 2 weeks, it's a critical time when all these things settle in, the cornea starts affecting, because initially with the swelling, edema, eye is closed, so you just can't relax after the initial week or two, because this might be a critical time. So how do we treat these epithelial problems? So teardrops, ideally with a ointment in the night as well, 4 times daily for a normal person, especially in ICU and when it's not under the ophthalmologist care. So if stain, give drops hourly. That means there is an epithelial defect, and start antibiotics 4 times. So you might need a frost suture. That's a suture which is like pulling the lip temporarily, and might need a temporary tarsorrhaphy, which tarsorrhaphy is a little bit of controversy because it creates a permanent scar for a temporary problem. So intermediate management is the problem of cicatrization or scar formation. So generally upper lid causes retraction. So it is pulled down, it doesn't close down. Lower lid, it's generally ectropion or lid is turning outwards, because the heat source is generally from outside to in. So this management of lid scars precedes other facial burn management, because it's a very functional part in the eye. Initially difficult to detect and obvious only after the edema and initial phase of the inflammation goes down after a couple of weeks. So other controversies to do the hysterotomy or not, because there are 2 schools of thought. One group thinks like you should keep it, because once you remove it, the defect is larger, and then healing takes a long time. So it's a case by case basis intervention. Delay skin graft till the lag ophthalmos or conjunctival signs appear. So split thickness or partial thickness versus full thickness graft. So how do you decide on an eyelid burn? So it's easiness to obtain. So sometimes the whole body is burned, scarred, so you don't have ideal places to get. So the partial thickness or split thickness graft, it's easy to obtain, but full thickness is a little difficult. And delayed contraction. So full thickness graft, because they have more collagen, it is thought that the contracture is less. But for cosmetic purpose, there is a opinion that, since it's a full thickness graft, cosmetically it's not as good as the split thickness. But generally speaking, the ophthalmologists, they take it from preauricular, postauricular, subclavian area, inner arm, but generally they give very good cosmesis. So for grafts, you have to have a viable donor sites, which is a challenge. Wound bed has to be good without contamination, with good blood supply. So when you do it, you can't, if there's a large defect, you can't do a whole graft at the same time. You have to have an upper lid with the upper margin. So if you have a large graft, you have to have two separate grafts. So upper margin in the upper lid is the skin crease, and lower lid you can just go under the eyelashes, subciliary incision. So you go around here. So you have to have a medial to lateral, canthal to canthal, or adequate incision for grafting. Then laterally, lower lid, you go 2 centimeters of lateral, and medially enough medially. And you have to stretch the gap as much as possible, because your problem is like not having enough graft. So graft has to be as big as possible. So stretch with the sutures the graft bed. So anterior you can dissect in further stretch. And for eyelid, for us, we full thickness graft is the one which is preferred, sutured on the recipient. Late, you can have vertical shortening and horizontal shortening. So if it's a vertical shortening, especially lower lid, what you can do is you can take a fascial arta or temporalis sling, and you can attach it under the eyelid. So this is kind of the lid margin kind of a thing. Then you can attach medially and laterally to the boards. And if the horizontal sling, you can release the lid laterally, and make sure you don't cut the skin. Spare the skin as much as possible, and do a lateral tarsal strip, which is like, you cut the tarsal strip, you make a strip out of it and attach with the non-absorbable sutures to the body margin, and later on mobilize the skin and cover. So tricky eyes is like, lashes coming and touching the eye. So correct if the eye position, if possible. Then what you can do is epilation is you take it out with a forceps. Then you can use electrolysis, that is, apply energy to the lash root bed, and cryotherapy. So medial canthal, other problem is the punctum tries to, ideally the eye is like a rounder structure. You have the tear film. To drain the tear film, the punctum has to look into the eye. But sometimes with the scarring outward, the punctum moves out. It's called punctal ectropia. This is commonly due to vertical bands in the area. Luckily, punctal and canalicular damage is very rare. So you might need some Ophthalmoplasties medially, not one, sometimes few, to correct this. And sometimes you can do the scar excisis and put a graft. And this we might have to do several times to have a reasonable outcome. So generally, for general burn management, you have to manage the pain initially, then cleaning and making sure it's not a site of infection, then debridement of the thing, then topical treatment, ocular protection. So oral analgesics with normal saline, daily cleaning, then debridement of especially second, third degree burns to prevent necrotic tissue clogging in the area. Then topical antibiotics, which heals with an ointment moisture effect, and sometimes steroids might be used to reduce the inflammation. So you need to protect the eye to prevent further injury. So follow-up, you have to make sure the patients are followed up once they are discharged from your care, to address further, to check the healing process, and to see the complication and management. If there's significant scarring, you need referrals for reconstructive. So scar management, you can give some topical treatments like gel, massaging, and if significant scarring, you can use steroid injection, PRP, as well as laser. So functional rehabilitation include addressing the malposition and lack of thalamus, that is inability to close the eye, and other functional issues. And you need reconstructive surgery if there's a functional impact. And always don't forget about the psychosocial support the patient needs. Some might even commit suicide with this, so you need to address and make sure they have minimal disfigurement as well as those areas addressed. So principles of management burns: prompt and adequate initial care is very critical. Ensure identify and to ensure optimal healing. Infection prevention, prophylactic antibiotics might be needed. Careful wound management. So it is individualized approach, not one way of managing each patient, the injury, their need, the psychosocial and their age, other medical problems also complicate issues. So multidisciplinary sphere, eye surgeons, oculoplasty, facial trauma surgeons, OMF, ENT, burns unit, plastic surgery, everyone comes into care, including psychiatrists and psychologists. So education of patient for wound care, to look for signs of infection, and the post-op follow-up visits are very important, and it has to be emphasized. Thank you.